Hello, my name is Mark Jaffe, and I'm an endocrinologist at the Kaiser Permanente Medical Center in South San Francisco, California. And I'm delighted to share with you today the Kaiser Permanente Northern California experience in controlling hypertension. We'll talk a little bit about how to control hypertension for our patients and our communities. Just to get started, I have no financial relationships with anyone other than Kaiser Permanente and the Center for Disease Control. I'm not an investigator for a pharmaceutical-sponsored trial. I don't speak at pharmacy-sponsored speakers bureaus, and I don't own any stocks in pharmaceutical companies. Those are my disclosures. Just a little bit about where I work. This is a small map for those of you far away in the Americas. But this is a map of the San Francisco Bay Area on the west coast of Northern California. Kaiser Permanente is a managed care organization, and we take care of more than 2.3 million adult members. We provide comprehensive inpatient and outpatient care. We have 21 hospitals and 45 medical facilities, and we employ more than 7,000 physicians. And my little medical center is this little diamond right here. And that's where I'm speaking to you from today. To take care of hypertension in the community and for our patients, we need to think of 5 essential components. And these are applicable to large organizations like Kaiser Permanente, where we have about 2/3 of a million people with hypertension. And these would be applicable to a small community practice or even an individual practice. The first thing is to identify the population. And we'll spend a few moments talking about that, because how can you take care of hypertension if you don't know who is at risk? The next step is to identify what it is that we'll be doing for those patients with hypertension. So we need to examine the evidence and create a guideline. The third part is we need a way to assess our performance, to evaluate how well we're doing, and we need to share our performance with one another. And then lastly, once we've done the first 3 components, we need to develop an efficient way to most effectively deliver those practices to the communities and to the patients who need our help. This article was published last summer in the Journal of the American Medical Association describing our processes and our outcomes. It's entitled Improved Blood Pressure Control Associated with a Large-Scale Hypertension Program. And I would point out that this could be done in a small scale as well. And the conclusion was that amongst adults diagnosed with hypertension, implementation of a large-scale hypertension program was associated with a significant increase in hypertension control compared to state and national control rates. Key elements of the program included a comprehensive hypertension registry, development and sharing of performance metrics, evidence-based guidelines, and medical assistant visits for blood pressure measurement, as well as single-pill combination pharmacotherapy. So step 1 is a registry, and this can be done if you're a country, can be done if you're a small community, can be even done in your own individual medical practice. We developed our registry in the year 2000, and we used all the information at our fingertips to come up with a list of everyone who had hypertension. We used outpatient diagnostic codes. We used information from the pharmacies about people who were taking medicines typically used to treat hypertension, and we collated information from the hospital. We assembled all of these and then audited a random sample of charts to make sure we had sufficient sensitivity and specificity. And after we did this, we came up with a hypertension registry. The next thing we did was to evaluate the evidence. And I won't spend a lot of time on this, but I will point out that the evidence is evolving. And in 2001, 2003, 2005, 2007, 2009, and 2011, we made subtle changes to our hypertension treatment protocol. This has to do with the initial use of thiazide diuretics and beta blockers early on in hypertension therapy. And you can see that over the years, the beta blockers have become less and less attractive and are now used really as secondary, tertiary, or quaternary hypertension medications and not used primarily. You can also see that starting in 2005, we started promoting the use of split-dose combination therapy, in our case, thiazide diuretic and ACE inhibitor, early in the treatment protocol. And I would point out that I'm not certain it really matters which is the best protocol or which one is the most appropriate, just that we do have a protocol. And I think that's the key element here, is that although one could argue about what's the best hypertension treatment plan, I think the best plan is any plan, is a plan that you can use reliably and consistently. So this happens to be our plan, and this is what we've used since about 2005. I think this is responsible for the bulk of our success. And you can see that in our care organization, we start with a combination lisinopril hydrochlorothiazide combination tablet for almost all patients. And we very deliberately picked the dose at 20/25, 20 milligrams of lisinopril and 25 milligrams of hydrochlorothiazide, because when this is taken 2 tablets daily, you get a maximal dose of a thiazide diuretic at 50 milligrams a day and a maximal dose of an ACE inhibitor. Now, of course, in your care setting, you might choose a different medication or different combination tablet, but I think the key here is that we really drive to a single tablet with 2 pills, and actually a single strength of that tablet. And we have our patients take a half tablet for a week or 2, then a whole tablet for a week or 2, and then 2 tablets. Again, we've got 2 titration steps with only 1 trip to the pharmacy and only 1 bottle. Our patients and our doctors really seem to like this a lot. For patients whose blood pressure is not controlled on full dose of a fixed dose combination therapy, ACE inhibitor, thiazide diuretic, we add a calcium channel blocker. The one that we use is amlodipine. The nice thing about this drug is that you can see a similar pattern here. The initial drug was 1/2 tablet, 1 tablet, 2 tablets, and you can see the second add-on drug is 1/2 tablet, 1 tablet, 2 tablets. It's a nice symmetry, and our patients and our doctors like this. It's very easy to implement. And you can see that now we've got 2 pills, 3 drugs, many titration steps with only 2 trips to the pharmacy, and for our patients, that's generally only 2 out-of-pocket payments. If that doesn't work, then we would add a 3rd pill, which is a 4th medicine. And whereas you would typically add a beta blocker in the past, we're really promoting the use of low-dose spironolactone now. And most of our patients with hypertension do have a thiazide diuretic already on board and do have a reasonable glomerular filtration rate and do have a reasonable potassium. And in that setting, low-dose spironolactone is very safe. Our primary care doctors are quite comfortable with this. After all, they frequently give spironolactone to patients who are much more ill, patients with severe heart failure and patients with cirrhosis. So giving spironolactone to patients with hypertension may at first seem a little unfamiliar to some of our primary care doctors, but we can reassure them that they're quite familiar with the use of this medicine, and it is quite safe in selected patients. Here's another description of our 1, 2, 3 process where we go lisinopril hydrochlorothiazide as a first step, then we add amlodipine as a second step, and then spironolactone as a 3rd step. I think the key here is that we have a plan and we have steps, and the doses are somewhat fixed. This makes it extremely easy for the pharmacy to stock the medications. It makes it extremely easy for us to titrate the medicines, and it makes it easy for the patients to effectively use these medicines. So after the 3rd tablet, so that'd be 3 pills, 4 drugs, there are a lot of options and very little evidence to guide us. And whether or not it's a beta blocker, an alpha blocker, minoxidil, hydralazine, et cetera, or even another drug. I think after 4 drugs, really the treatments really need to be tailored and individualized. So what drug guideline is the best? And I took this right out of the CDC PAHO Guideline Treatment Standardization Project for Hypertension, which was developed in March 2013. And I think these are really important points, that a standardized, protocol-driven, facilitate the use of a single hypertension treatment guideline is essential, and I completely agree with that. Within a country, a single treatment protocol developed by key stakeholders, that's nationally relevant, evidence-based, clear, simple, and implementable should be used. So if one care setting wants drug A, B, and C, and another care setting wants drug X, Y, and Z, I think that's entirely fine as long as everyone can rally around a single treatment protocol. And not only that, but the medicines should be integrated into the guidelines and should be available. And we've been able to procure low-cost, effective, safe, reliable, affordable generic medications. So what drug sequence is best? Well, this is my opinion. I'm just quoting myself, but the implementation of a consistent drug treatment care pathway is important to facilitate system-wide improvement in hypertension control. There are many drug escalation pathways, and it's not clear if any one drug is better than any other. So I think the most important thing is in your individual practice, in your group practice, or in your national practice to identify a treatment algorithm, make sure the medications are affordable, that you're familiar with them, and try to drive towards a single implementable system. And that, besides coming up with the important drug treatment sequence, we have quality improvement and accountability throughout our culture. So we have annually quality goals. We share the information with one another in an unblinded fashion so everyone knows how everyone else is doing. We have a central hypertension management team who's responsible for identifying best practices. We have physician champions and leaders at the medical centers who support the clinical care. We identify the most successful programs and label them best practices and share them throughout the regions. And we provide the feedback to the clinics and to the doctors and nurses, but mostly to the clinics, so the clinics can organize their care. After all, sharing it with the information with the doctor is useful, but sharing the information with the clinic director is even more useful because the clinic director is in the position to implement system changes. So here's some of our results. You can see that in the year 2001, our control rate in the blue was about 44%. And little by little, we got our control rate up to 90% when we last checked. And this is really remarkable because when I first started practice, more often than not, patients would have uncontrolled hypertension. But now it's a rare patient whose blood pressure is not controlled. So 9 out of 10 patients have their blood pressure controlled. And it really takes a lot of hard work and dedication and persistence, but it can be done. And you can see that our rates compare favorably with other United States national rates at 64% and California rates at 69%. I would point out that many people ask us, what happened in 2005? And I would point out in the paper that the confidence intervals are quite sloppy for our national reporting metrics, and that's because although we have 650,000 people with hypertension, the black dots reported nationally are on a random sample of about 250 patients. So what we do internally is we monitor our performance internally through these open dots here. Confidence intervals are extremely tight, and you can see that there was really nothing that happened from 2004 to 2006, nothing special. This was a very, very gradual increase over the open white dots. I'd also point out that the use of our single pill combination therapy is quite extensive, and now we have almost 30% of our patients who get a prescription for an ACE inhibitor have it in combination with a thiazide diuretic. So again, we had very little use of fixed dose combination therapy in 2001, and now 30% of our patients are on that in 2012. We think that's a key driver of success. We also have a medical assistant blood pressure check where instead of coming to the office, our patients will return and see a medical assistant. We don't charge for this. It reduces white coat hypertension, and it's a way for specialists who identify high blood pressure to get the patient back to the primary care team where the blood pressure can be measured in a consistent fashion. Has it been effective? You bet. You can see that our total mortality in the thin red line here has fallen over the period of the implementation. And you can also see that in an era when we've been able to identify non-ST segment elevation MIs using sensitive markers in the ER, we saw an initial increase in it, but we saw a reduction in total heart attacks and the worst heart attacks over the study period. So in summary, the way we were able to control hypertension was to develop a registry with performance metrics, to develop clinic level feedback, to have a treatment algorithm which is evidence-based and simple, to have single pill combination pharmacotherapy, and medical assistant blood pressure checks. I'd like to thank many, many people who helped me, but most notably the 7,000 physicians and the 2/3 people in my medical center who've helped control our patients with hypertension. Here are some references. Thank you very much, and I hope you've learned something from this presentation. Bye-bye now.